We want to invite everybody back in. We are excited to have what for me is always the absolute highlight of this. Of course, that's a very paternal behavior, but we have our graduating residents. So here's the format that we're going to use for the next 2 hours. Each of the residents will be giving a 15-minute presentation. Following their 6 presentations, we will then have a half hour for questions. As you can see, we'll have them all sitting up here, but that'll only take place after they've given their individual presentations. So at the end of their individual 15 minutes, they will trade off with the next speaker, and following that, we'll bring them all back up. And when they're all up here, we'll address questions to the group or to specific individuals. So keep track, because you have an hour and a half to remember your questions from the first talk. So we allow you to take notes or memorize whatever your questions are going to be. They will tell their name and where they're going, and then they will give their presentation. And I'll turn the time over to Derrick for the first shot.
Maybe we'll get started. So my name is Derrick Hall. I'm a third-year family medicine resident at McKay-Dee Hospital. And once my slides come up, I'm going to be presenting about injury and Snowsport. Okay, here we go. So I just introduced myself. What? I'm getting there. So after I get done with residency next month, I'm going to be taking a month off to get married to this beautiful woman, and then we'll be moving to Portland, Oregon area where I'll be practicing. I'd really like to give a lot of credit to Clark Madsen, who did help me a lot with analyzing the data that I was able to gather. And full disclosure, I am a snowboarder. I'll try not to be biased, but all the pictures in this slideshow are my own, except for the picture of Portland that I just showed. And otherwise, I have nothing to disclose. So first of all, I kind of want to talk a little bit about the ski industry as a whole and kind of some of the research that's been done about the different injury patterns within the sport. So first of all, there's about, in the year 1935, there was approximately 10,000 skiers in the United States. It has grown exponentially since that time. There's now over 15 million. There's estimated to be about 200 million worldwide. There's 14 ski resorts just in the state of Utah. There's 481 ski resorts in the United States. If you look over on the right, there's a map. Each one of those dots represents a ski resort. As you can see, there's ski resorts on every continent, and actually the country that has the highest concentration of ski resorts is not the United States or Europe, it's Japan. They have more ski resorts just in Japan than they do in all of the United States. So injury is a real thing among skiing and snowboarding, as all of us are probably very well aware living in a state like this. So the alpine skier injury rate is approximately 2 to 4.4 per 1,000 skier days. So for every 1,000 days that people go skiing, there's about 2 to 4.4 injuries. It's actually a relatively safe sport. So there's an average of about 38 fatalities per year at U.S. ski resorts. And you compare that with some of these other, that equals out to be about 1 fatality per 1.26 million skier visits. I have a little infographic on the left that shows the comparison with some other sports. So hang gliding has a 1 in 560 chance of dying. So I probably wouldn't recommend that one. Even running and jogging has a higher rate of death than skiing and snowboarding. People who tend to get injured are typically males, and most fatalities and catastrophic injuries don't occur on the double blacks and triple blacks. They occur on the blue square groomed runs. So since, for the past 2 to 3 decades, the incidence of the rate of skiing incidents dropped from 3.1 per 1,000 visits in 1980 to 2.5 per 1,000 visits in 2011. Snowboarding has also been on the decline. It was about 6.97 per 1,000 visits in 2001, and it's now down to about 6.1 per 1,000 visits. So it's more likely to get injured if you're a snowboarder. And why have these changes occurred? There's been advances in equipment safety that have definitely played a role. New hardtop boots, for example, for skiers, which I have a slide that I'll kind of talk about that a little more. Improved resort safety has also played a factor. Improved helmet use has also played a significant factor. There's different injury patterns between skiing and snowboarding. First of all, in skiing, there's more wrist injuries, as you can see. Or snowboarding, there's more wrist injuries. In skiing, there's more knee injuries. So in general, there's more upper extremity injuries in snowboarding, more lower extremity injuries in skiing. And there's an increased rate of injury among snowboarders, especially in beginners. Almost 50% of injuries among snowboarders occur on the first day of taking up the sport. So this is just some data. This is taken from a Japanese study where they analyzed 10,000 visits, ski injury visits to clinics. So instead of looking at, it's kind of an overwhelming chart, but I wanted to draw your eyes, first of all, so this is just talking about skiing. And there's significantly more lower limb injuries among skiers, where you compare the numbers for snowboarding, and there's significantly more upper limb injuries. Almost 53% of injuries among snowboarders are upper limb injuries. So this comes from the same study, and my point in bringing this up is I wanted to show some of the patterns over time. It breaks down and looks at the types of injury and how common they are, and it compares that with what time period it was. So if you look over on the right, it shows that sprained ankles used to be the 4th most common injury, and if you follow the red box over to the left, it's now the 8th most common injury. And at the same time, lower leg fractures have actually been on the increase. It's been gone from 6.2% of injuries to 10.1%. So this is kind of the changes that can happen with improved equipment. So the advent of hardtop boots for skiers is what is predicted to have caused this change in injury pattern. So I wanted to tell a very brief story. So I had the fortune a couple of years ago to go skiing in Japan, which is an incredible opportunity, and all of you should do it if you can. So I was on my second to last day there. I was skiing down a run, and it was very cold, very foggy, and I was in some trees, and I caught an edge, and I ran into a tree. I have it on video, so if anybody wants to see it, I can show it to you later. But it got me, as I was trying to come up with a project, it got me thinking, are there things that affect the injury types? So in that injury, I broke a rib, which hurt like the dickens. But it got me really thinking about, is there things that we can understand better about what causes certain injuries that will give us a better idea of how we can prevent those in the future? So my hypothesis was that weather conditions play a significant role in the type of injuries sustained in skiing and snowboarding. I analyzed 512 patient encounters from a single Utah ski clinic, and identified several different factors, including birth date, age, gender, date of injury, injury type, whether or not a fracture had occurred, whether they were from Utah or not, and whether they were skiing or snowboarding. Injury type was then categorized by the major body part affected. And then I was able to contact the National Weather Service, who showed me the image on the right is from a website called Meso West. They were able to give me access to the information from all of the weather stations in the United States. And so I was able to find one that was located at Mid-Mountain at the resort that I was looking at. And so I took that data and then analyzed that further to come up with the daily high temperature, daily low temperature, and snow depth. So using that information, we analyzed each factor in comparison with the injury types. My patient population, again, consisted of 512 patient encounters, dates ranging from December 2015 to March 2019. Ages ranged from 4 to 83. I have the age distribution of my patient population on the right. So there was more injuries among the younger population than there was the older population. There were 145 snowboarders, 313 skiers, with the remainder being unknown or non-ski related injuries. 181 of those injuries were fractures. Snow conditions, the snow depth ranged from 15 to 110 inches. The lowest temperature recorded was -1 degree, highest temperature recorded was 60 degrees. So I compiled that information into these box plots. So this looks at the injury type on the y-axis, and on the x-axis you have the daily high temperature in this first box plot. And what we're looking at is kind of the average. So there's not real, in seeing if one box is a little further to the left, one box is a little further right, all of them seem fairly well aligned. We didn't really find much of a pattern comparing what the high temperature was of the day with the injury type. This is looking at the daily low temperature. And again, we really didn't see a whole lot of a pattern one way or the other. And then this is looking at the snow depth. So at first glance, it might appear that there's more pelvis injuries when the depth is lower. But you have to keep in mind that there was only I think there was 3 pelvis injuries within my data. So we had all this information. So we kind of looked at my original hypothesis and those different weather factors to try and determine, and those didn't really have much of an effect. But we had all this data. We wanted to see if there was anything new that we could add to the current research that's been done about injury in snow sport. So this is looking at skiing versus snowboarding, and injury. So it's the proportion of injury type by the sport. So over 40% of injuries in skiing were knee injuries. And there tended to be more knee injuries, leg injuries, and also, interestingly, lacerations in skiers compared to snowboarders. And snowboarders had more shoulder and wrist injuries. The only that's consistent with the rest of the data that I reviewed, but it did show that there was more lacerations, interestingly, among skiers. This is looking by gender, and this is also something that's very interesting, that there's almost over 40% of injuries among female participants are knee injuries, compared to only about 20% with males. Vice versa, you have about 35% of injuries are shoulder injuries in males, compared to 12% in females. I then took a look at age to see if age had played a factor. So you can see that in the younger population, there seemed to be more head injuries, face injuries, arm injuries. And in the older population, you tended to have more chest injuries, which consist of fractures, bruises, things like that. We then ran a binomial regression to compare each. So we wanted to look at fractures specifically. So we ran a binomial regression to compare each variable with fracture rates. We did find one thing that was significant. First of all, there was a 54% increased likelihood of snowboarders to have a fracture compared to skiers, p-value of 0.01. And then there was a trend towards more fractures among patients who are from out of state. That may speak to experience level but it wasn't quite significant, but trending that way. So in summary, these are the things we learned. First of all, temperature and snow depth don't really appear to have much of an effect on injury. Females tend to have a higher rate of knee injuries than males. Males tend to have a higher rate of shoulder injuries than females. Older patients tend to have more chest injuries. Younger patients tend to have more head and arm injuries. Snowboarders have a higher risk of fracture as a whole, and males tend to be more prone to fractures. So what are the implications of this? Again, as I spoke to earlier, advances in equipment and things like that can change injury profiles. And so really the goal is to make this a safer sport for everybody. So we can use this information to develop better protective equipment for the sport. It can improve ski patrol and clinic physician awareness of what injuries they might expect with certain conditions. Can also improve participant awareness of the risks that they're undertaking by starting this sport. There were some limitations. Here's just a couple of them. But first of all, high and low temperatures, snow depth, they might not be the best predictors of snow conditions. So one thing that I wanted to look at in the future is snow surface conditions. I wasn't able to get my hands on that data for this project, but I wanted to look at snow surface conditions. So powder day versus a groomer day versus an icy day versus a slushy day to see if that plays any role. And also patient data was only gathered from one ski resort, and so one ski clinic at a ski resort, and so kind of which leads to my next steps. I'd like to increase the comprehensiveness of this data by obtaining complete injury data from multiple resorts across, at least this general area. I'd also like to compare type of injury to snow surface conditions, as I mentioned before. And I'd also like to compare the amount of new snowfall, which is an indication of a powder day, with the types of injury and also the frequency of injury in general. So are there more injuries that occur on days, on powder days or on icy days? So that's my project. So I'll take questions at the end once everybody else is done with their projects. Thank you.
Well, good morning, everybody. We're going to see if this works real quick here. Perfect. My name is Jeff David. I also am a third-year family medicine resident at McKay, and during my second year of residency, I started working part-time at an addiction clinic at the Community Behavioral Health Center here in Ogden at Weber Human Services. And I'm actually going to continue there as the medical director after residency, and we're going to work on providing primary care for those patients, and I'm excited to be able to have the opportunity to do that. The work that we were able to do there led to the research project that I'm going to talk about today, and that is the rapid transition from a full to a partial opioid agonist in patients with chronic pain. And I'd like to thank my friend and faculty member, Dr. Tim Derrick, our clinical pharmacist who helped me put this together. And to start, I'd like to share some earth-shattering news with all of you that I'm sure you've never heard before, and that is that opioids are dangerous. Who knew, right? I'm sure this is the first time everybody here has heard this. And unfortunately, in the media, sometimes it can feel like we're a little bit vilified as prescribers when we've used these things for people. And I've occasionally found myself feeling like, well, fine, then I'll use opioids on anybody. And unfortunately, that leads us to a kind of a situation where we're kind of danged if we do and danged if we don't when it comes to opioids. And some of the reasons that we're danged if we do is that these medications can cause respiratory depression, which is usually how people die from them. They can cause CNS suppression, lead to automobile accidents and so forth, diversion, crime. They can interact with other medications, specifically benzodiazepines, and kill people. However, on the danged if we don't side of things, there are people who have legitimate pain, and they can and will experience withdrawal if we yank these out from underneath them. They are dependent on these medications. They may have tried other things, And if we exhaust those other non-opioid options to the utmost extent, sometimes we can have problems with them as well, like gastritis, renal problems, if we're looking at NSAIDs, for example. And additionally, if we yank them out from under people, then oftentimes that will lead to them transitioning to heroin or something potentially more dangerous. So the question becomes, well, what if there's another way? What if we could still use an opioid but do so in a safer fashion? And one option for doing so is the opioid buprenorphine. And it's kind of unique in comparison to some of the other opioids. Things that are different about it, it is a partial opioid agonist, so it binds to the receptor, the mu opioid receptor, but it doesn't activate it to the same degree that you get with a full opioid agonist. And that gives it some special properties. There's less physical dependence, there's less sedation, constipation, and notably, there's less opioid-induced hyperalgesia. And when you use this medication, a real noteworthy benefit is that it has a ceiling effect when it comes to respiratory depression. You can continue to increase the dose to a certain point and get increased analgesia, but you don't increase the likelihood that your patient's going to stop breathing on you. Buprenorphine has really poor oral bioavailability. It has a high first-pass metabolism and consequently has to be administered typically sublingually. There are some other dosage forms, intravenous, a topical version, but typically it's going to be sublingual. Most of us are familiar with this medication in the form of medications used for opioid use disorder such as Subutex or Suboxone when it's combined with naloxone to prevent intravenous abuse. Something that's really special about buprenorphine as well that makes it valuable in patients with opioid use disorder is the fact that if they relapse while the buprenorphine is occupying those receptors, it'll protect them because the buprenorphine has a higher affinity for the receptor, so it's going to hang on to that receptor tighter than what the oxycodone, hydrocodone, heroin, et cetera, are able to. And that'll stop them, or that'll protect them, again, if they did relapse. However, on the other side of the coin, it also can cause us problems when starting the medication because if those opioids are in their system and we give a dose of buprenorphine, that buprenorphine is going to go into that synapse. It's going to push those other opioids off the receptor and put our patients into an abrupt and fairly severe withdrawal that can be really uncomfortable. And when it comes to withdrawal, we read about it in a medical textbook and we say, okay, it's kind of just like a mild flu and they'll deal with it and be fine. They're going to have some dysphoria, they're going to have some muscle aches, some joint aches, some gastrointestinal symptoms, runny nose, watery eyes, or whatever, but they'll be fine. In some people, however, it can be a really big deal. And I had one patient, for example, who his withdrawal was so bad, he cut off 2 of his own fingers in order to avoid being questioned when he went to the emergency department, like, no, seriously, don't mess around with me, I need opioids. Other patients that I've had in their early 20s, early 30s have already spent a fourth of their life in the justice system and incarcerated because of impulsive and desperate decisions that they made while in withdrawal or trying to prevent withdrawal. So it's not just a benign thing. Because of some of these nuances involved with buprenorphine, using it for opioid use disorder requires special training, and that consists of an 8-hour course for physicians, or for nurse practitioners and physician's assistants, a 24-hour course. Thereafter, you're issued a new DEA number that begins with an X, and that number needs to go on prescriptions that you're writing for buprenorphine when treating opioid use disorder. However, if you're using it for chronic pain, that's not necessary. And you can just put for pain on the prescription, and the pharmacy will be able to fill it for you without any problems. Because of some of these nuances of the medication, oftentimes it's not utilized much in our individual clinics, and more so at places like community behavioral health centers such as Weber Human Services or Davis Behavioral Health. And that lack of familiarity with it makes us uncomfortable with it sometimes as providers. Even though it has all these advantages that would make it valuable for us, it can sometimes be a little bit intimidating to use for the first time. And that happened once with one of my attendings. Because I'm a classy guy, he'll go unnamed. But he approached me and said, hey, I've got this patient I'd like you to see. He's on a lot of oxycodone. He's on 180 morphine equivalents. And we've tried to taper him off before, and it just hasn't worked. We've got him off of his benzos, but he's run out early on his oxycodone. He actually used heroin once when he couldn't get hold of me when he ran out. And so I want him to come see you, but he doesn't really want to, and he's not really excited to see you. But I'm going to make him. And with a sales pitch like that, this is kind of how I felt inside. And I thought to myself, well, I'm excited about this opportunity to actually do something genuinely useful for my attending for once instead of just answering a question he already knows the answer to. And so I looked up if there was any special considerations I needed to be aware of when using buprenorphine specifically for pain rather than opioid use disorder like I usually used it. And there are only 2 FDA-approved dosage forms when you're using buprenorphine for pain. One is a buccal film, and the other is a transdermal patch. And when they did the studies on these medications, they only used a limited morphine or patients who were on a limited range of morphine equivalents of opioids. And so when you look on UpToDate about using up buprenorphine for pain, it'll say not to do it with patients that are on more than 30 morphine equivalents. Our guy was on 180. I thought, well, that doesn't help me. And when you look at the package insert, it says you can go up, you might be able to go up to as high as 160 morphine equivalents on the buccal film or 80 with the transdermal patch. Again, my guy still falls out of that category. But it didn't make sense because we do this all the time in patients with opioid use disorder who are on tons of heroin and way higher opioid or morphine equivalents than what we're talking about in this scenario. And if you're going to taper down, this guy had already struggled with that. It's complex. It takes a long time. Those dosage and those products that are approved for pain specifically are more expensive than the ones that we normally use in the form of the sublingual tablets and films. So, and he fell outside of that window of the range that they used for the study on those products. And in thinking about this, again, we thought, well, this doesn't really make sense. And like any good resident, when I find myself in a situation where I don't know what to do, I try to find somebody smarter than me. Not sure what that was, but so I reached out to Dr. Jeremiah West at the Chronic Pain Management Clinic in Layton, and he was great. And he said that, no, I switch people over all the time, and it just so happens that I keep a record of all the new patients that come and see me and how they do over time, and he offered to share that with me. And that worked out perfect because I needed to do this research project. And so our hypothesis was that these chronic pain patients who are on full opioid agonists could be switched over to a partial opioid agonist and that could be done in a rapid way after just 24 hours, just like it is with patients with opioid use disorder. And prolonged tapering doesn't have to be done. So in looking, well, has anyone done this before, we found a couple of observational studies that showed that yes, people have done this before, and they did use the cheaper sublingual films and tablets to do it. And they were observational studies. The one had a little over 100 patients, the other had a little over 30. And the chronic pain scores, the pain scores in those patients on a scale from 0 to 10 decreased by 2.5 in one group and 3.5 in another group. So they had pretty good success. They switched them over after 24 hours. They went up to, I think, 16 milligrams initially and then up as high as 32 milligrams on the buprenorphine dose. And again, people did well. So our study was also observational. We looked at 267 patients who presented to Dr. West's clinic between October 2017 and January of 2019. And we were looking for patients who came to him on full opioid agonists and were thereafter subsequently transitioned to buprenorphine. When we rummaged through his numbers, we found 32 patients who attempted to transition to buprenorphine. And when we asked Dr. West, well, why did you try with some and not the others? It was a clinical decision that they would make, and most of the time it involved people who just weren't doing well. They were running out of their medication early. They were using more of it than they were supposed to. They were becoming preoccupied with it. It was causing problems in their life. And essentially, it boiled down to those patients who were showing signs of opioid use disorder, which in a nutshell has 11 different symptoms in the DSM, but it's four main areas. They're losing control of their use. They're having problems in their social life because of the medication. They're using it in risky situations that are negatively impacting their health, and they have signs of dependence and tolerance. When we looked at those 32 patients, we excluded 7 of them. 3 of them didn't follow up. A couple of them, 2 were already on buprenorphine. One poor guy just kept getting surgery after surgery for another medical condition and wasn't able to follow through. And then one patient was just on a really high dose of methadone and required an inpatient transition to buprenorphine. And methadone's a little bit special. If you're going to transition someone from methadone to buprenorphine, you need to wait 72 hours before you do it. And typically, you wouldn't want them on more than like 30 to 60 milligrams of methadone. And that might be someone to refer to someone like Dr. West. So that left us 25 patients. And among those 25, 14 were female, 11 male. They were 31 to 65 years old with an average age of 51. And they had a pretty wide range of morphine equivalents that they were on, 5 to 550, and on average about 130. And they were the common culprits, the fentanyl, hydrocodone, hydromorphone, meperidine, morphine, oxycodone, that we see all the time. Out of that group, 84%, 21 of them, were able to successfully transition and reach a stable dose. And we defined a stable dose as the time period between 2 prescriptions filled for buprenorphine that did not have a change in dose, which was kind of arbitrary, but that led to when we looked at that, on average it took people about 31 days. That doesn't mean it took them 31 days before they felt good, but there was just 31 days that lapsed between the first prescription and the second prescription without a change in dose. The doses that these people were using ranged from 2 to 24 milligrams per day, so pretty broad. On average, it was about 15.3, and that's typical. Most patients with buprenorphine are going to do well at around 16 milligrams or below. And one patient actually did use the FDA-approved products for pain, but the others were all on the sublingual tablets or films because they're cheaper and more readily available. The folks who didn't do so well, there was 4 of them, and they didn't have a particularly high morphine equivalent that they were on. It was 3 to 120 milligrams, 3 female, 1 male. There wasn't anything especially noteworthy about their oxycodone, or their pre-buprenorphine opioids that included oxycodone, hydromorphone, hydrocodone. So, like those previous studies, observational studies that I mentioned, our study also showed that buprenorphine, which is a mouthful to say, is a viable option for our folks that are struggling with chronic pain, and something that we should consider. And so, given those advantages, which include constipation or decreased constipation, sedation, decreased likelihood of respiratory depression because of that ceiling effect, decreased opioid-induced hyperalgesia, and that protective effect if they do overdose or relapse, it's something that we should consider. It has, again, a lot of advantages that can be helpful for patients that I'm sure most of us have a couple of in our clinic. It's especially valuable for those patients with signs of opioid use disorder, that they're running out early, they're just kind of struggling. It's a good group to consider. If you're going to switch to buprenorphine, if you don't remember anything else about this talk, the big thing that we want to do with it is just wait 24 hours from their last opioid use so that you don't precipitate withdrawal by pushing the full opioid agonists off of the receptor when you give them the buprenorphine. Other things to remember, most people are going to do well around 16 milligrams per day. The dosage range goes from 2 to 24. At 16 milligrams, every mu opioid receptor is saturated. You can get some increased agonist effect up at higher doses, up to 24 milligrams, but typically there's not a reason to go much above that. The sublingual tablets and films, while not FDA approved, are much more readily available, and they are cheaper. And in 2004, the DEA acknowledged that using them off-label for pain is legal. The buprenorphine is still an opioid, so it's not a magic bullet. It still has risks of other opioids, especially if you use it concomitantly with benzodiazepines. So if we want to try those other non-opioid options first, but keep this in our back pocket. And if we're going to use it for pain, we don't need that Data 2000 waiver. We can just put for pain on the prescription. So yes, we essentially reestablished that buprenorphine works for opioid use disorder, but a lot of our patients that we see for chronic pain fall into that category in at least to some degree, so it's worth considering. And that's all I've got. I'd like to thank everybody who helped me, and thank you much.
Whoa. All right, good afternoon, everyone, or morning. I don't even know what time it is anymore. My name is Stodmeister. I'm one of the other residents. After this, I'm heading back to my home state of Nevada to practice at Renown Medical Group in Reno, Nevada. I'm giving my presentation today on lead level screening in northern Utah. I've got nothing for disclosures. So let's just briefly kind of go over what lead is. Of course, it's a heavy metal. It's known to be soft and malleable, relatively low melting point, which is good for soldering. Its number is 82 on the atomic scale. It sits comfortably between bismuth and thallium there. It has been used forever. The first evidence of lead smelting was found to be back in 7,000 to 6,500 BC. It's been used from everything to weaponry, to currency, and even plumbing. The ancient Romans, because of its malleability, found it the perfect solution to pipe in water and build a plumbing system. That, of course, led to some issues. There's some historians that believe that the lead piping in their ancient plumbing system is what led partially to the downfall of the Roman Empire. Now, of course, today we know it as an awesome substitute for paint in certain Chinese toys. Some of you might remember the Thomas the Tank Engine crisis of 2007. These, among other toys, were recalled because of the elevated level of lead they used in their paint. My favorite of these here is this guy here, the scented orange barrel car, where it's a kid toy filled with lead you had to put right up to your nose and mouth to smell it. Not the best use of lead. Mostly because, of course, we know the toxic effects it has on the body. Some of them, most notably, you would remember from med school and those board questions, is the heme biosynthetic pathway. At certain lead levels, we start seeing anemia. We start getting that basophilic stippling within the erythrocytes. At low or even higher levels of lead in the body, it can actually cause a hemolytic anemia. There are issues with the endocrine system. It decreases the amount of vitamin D we take in and increases the amount of lead that goes into our bones. Of course, we can see these on x-rays, as well as the lead-lined gums, also on some step tests and board questions. The renal system, it can actually cause a chronic interstitial nephritis. And we see decrease in renal function at levels even below 10 micrograms per deciliter. People who have lead level poisoning often complain of gastrointestinal issues. They call that lead colic. Some of the more severe and concerning issues with lead, of course, it can cause an acute encephalopathy at very elevated levels. Peripheral neuropathy has also been seen at pretty low lead levels, even below 20 micrograms per deciliter. And of course, it can also lead to increases in fidelity in DNA and RNA polymerase, causing germ cell and somatic cell mutations, causing cancer in rodents. What I'd like to focus on a little bit here as far as the effects of the neurobehavioral effects. We've seen diminished academic abilities, attention deficits, problematic behavior such as aggression and impulsivity, a relative association with ADHD, even in people with lead levels below 5 micrograms per deciliter. Some studies even shown that children with blood lead levels greater than 5 have an IQ deficit of 6.1 points. Now, these effects, even though a lot of them hit when in childhood, are irreversible. So even if the lead level clears, these effects from that elevated lead level continue on into even adulthood. We're in a point right now where we call a prevention paradox. Of course, screening for lead level, we use right now 5 micrograms per deciliter to determine as the definition of elevated lead level. It used to be 10, but more and more the studies show that no level of lead in the body is safe. And so if we just use 5 as the cutoff for an elevated blood lead level, we're failing to preserve more than 20 million IQ points in children across the United States. Now, like I said before, it used to be 10 micrograms per deciliter. In 2012, the CDC changed it to 5 micrograms per deciliter as the definition. Utah followed suit in 2017, changing our reporting recommendations to anything above 5 micrograms per deciliter. Of course, this is a bigger issue if you come from an emerging market, industrial market, where we see issues from just not neurobehavioral issues, but deaths across a lot of areas. And there's just a big global burden, said to account for 63.8% of the global burden of developmental intellectual disability. Here, of course, are some of the screening recommendations that we have. The AAP leads with their recommendations with screening at federal, state, local requirements, mostly in high prevalence areas. High prevalence being described as greater than 27% housing built before 1960. And the CDC recommends screening areas of increased risk for lead exposure, much like the AAP. The AAFP, they actually recommend against screening in asymptomatic children. The USPSTF has recently changed, actually just last month, to a level I statement saying that the current evidence is insufficient to assess or give any information on the benefits or harms for lead level screening. Of course, Utah state screening follows suit with AAP and CDC. It is recommended we're screening any children who lives in a zip code that has 27% of their houses built before 1950. And of course, anyone living in a house built before 1978 should also be screened, as well as anyone answering yes to a questionnaire. Do you have a house built before 1950? Are your friends or your kids play in those houses? Do you know anyone near you that's been diagnosed with an elevated blood lead level or lives in a mining area? They should be screened as well. So that came to the question I had, and it is, well, how are we doing with our screening across northern Utah, especially in Morgan, Weber, Davis County? So my study objective was to assess the percentage of children who have undergone lead level screening who live within the areas identified as having 27% of housing built before 1950 within Weber, Davis, and Morgan County. And then, of course, just to assess the overall prevalence of lead level screenings across Weber, Davis, and Morgan counties. So we went data mining, essentially. We used the EMR, the electronic medical record we use at Intermountain Health Systems, known as Icentra. We found all of our pediatric population, any patient under the age of 18. We then looked for their addresses, if they had an address listed in Davis, Morgan, and Weber counties, and then to see if they had, of course, lead level screening. We used both the capillary and venous, either one. The new recommendations from USPSTF is that we just do capillary screenings, and that's the same with Utah State as well. And then we took that data and then looked at the prevalence of elevated lead levels and just the percentage of screenings we are doing with those at-risk children within specific zip codes. Now, the state of Utah, the Utah Health Department, of course, has a list posted online. If you don't live up here, you live somewhere else in Utah, you can look it up to see what zip codes have houses at a rate of 27% of them built before 1950. Up here, of course, we're focused on two of them, zip code 84401 in Weber County, and then in Morgan County, 84018. Davis County actually doesn't have any zip codes where they have housing built before 1950 at greater than 27%. So those are the two ones that we were concerned about. So we took all that data, we grabbed our calculators, returned to the nerdery, and of course made some cool graphs to show to you all today. So we found a total of 19,800 pediatric patients. Of those, 452 were screened. Here's some histograms of that data. Now, back at the recommendations, of course, we want to screen anyone under the age of 4. So those who we are screening, we're doing the majority before the age of 5, which is great. That's right where we want to do them in that area. Now, if we look here, the histogram on the right, which shows the lead level of those that are screened, our red line here is essentially the danger zone, what we consider an elevated lead level of 5 micrograms per deciliter. We have quite a few that are found even beyond that marker. What's even more concerning, I think, is those who are below that 5 micrograms per deciliter, who enter essentially in that the prevention paradox we talked about earlier. So these pictograms represent some of the data. So on our x-axis, we have the percent that are tested. On our y-axis, the cities. Each circle represents a zip code within that city. The bigger the circle, the more children we've tested. A couple of things I'd like to point out. First off is Morgan. We only have 2 dots for Morgan. There are several other zip codes within Morgan, one of them being a lead level a zip code in which we need to be screening. Nobody was tested in that zip code. This dark purple one right up here represents the 84401 in Ogden, which has greater than 27% of the houses built before 1950. So we are capturing some children in that. What's kind of crazy, though, if you look at it, it's not a zip code that has the greatest amount of children tested. There are also a couple other things that we didn't include. Bountiful, while there's a few here, in order to get the graph to fit on the PowerPoint, we had to chop one off at Bountiful, who in one zip code had around 80% tested of those who were living in that specific zip code. There were some questions as to whether that zip code included both Bountiful and northern Utah, if there was some changes to the boundaries of that zip code. Because of that, we decided to not include that in the data. Now, same color for the same zip codes. And if we look back at the 84401 up in Ogden in Weber County, that while it was not the one with the most tested, it was one that had the highest percent of positive tests, that is greater than 5 micrograms per deciliter. Now, we might recognize Eden here too has an elevated percentage of positive tests. Looking back at the data, there's only about 2 to 3 kids who were tested all kind of in the same family. And they essentially were buying Thomas the Tank Engine toys, and that's why that was elevated. So we have essentially an area where we don't have as much testing, yet an area also has the highest prevalence of elevated lead levels. Now, one great thing about being up here and doing these things is the ability to disseminate this local information to this group. And so in order to do so today, we created an infographic kind of hopefully to help disseminate the information, the data that we found. To kind of zoom in on this, a couple things to point out. So in Weber County, we identified 1,817 patients that meet the criteria for screening. We only screened 168. In Morgan County, the one zip code there, we identified 12 patients that met the criteria, and of course, no one was screened there. That means our screening rate within the high-risk areas in which we checked was only 1.5%. Of those screened in the high-risk areas, the percent found to have an elevated blood level was 36%. So a bit of a discrepancy between who we're screening, when we're screening, and the amount of elevated lead level tests that we find. There's Utah Lead Coalition that was set up in 2017 after the Flint, Michigan lead crisis. They estimate that 2.5% of all preschoolers in the state of Utah may have an elevated blood level. That's 6,000 children within Utah that could have an elevated blood lead level. We checked only a very, very small percentage of this. Now, the U.S. prevalence of elevated blood level is going down slightly. So the question is, and the prevalence is at 0.8%. The prevalence, of course, in the areas we checked was much higher than that. So is there a problem? We don't know. We just don't have the data. We're not checking, we're not screening the population to an extent where we can confidently say there's a elevated or an increased prevalence than the national average. Is Utah at higher risk? We used to be a mining community. We just don't know. That data isn't there. We're only screening 1.5% of those who need to be screened. That's not total population. That's just of the population that we know we should be checking a capillary blood level on. Now, limitations, of course, the study only looked at high-risk zip codes. We only looked at patients in the Intermountain iCentra system. And because of that, we only looked at when iCentra went live back in 2015 through 2019. So we're not capturing a huge population, but 19,000 is a good start. Of course, this does hit close to home. There's been some issues of lead level here in Utah. Just recently, back in February, because of an increased amount of fluoride going through the system, Sandy's water became undrinkable because of elevated lead and copper levels. This is something that is to be dealt with at a local level. It is stuff that we see right here at home. The USPSTF, as I mentioned before, they put out new recommendation of I, meaning there just is insufficient evidence to decide whether it is worth it to screen or not. They said the same thing. There's just a lack of evidence. Furthermore, all the studies that they looked at, the lead level cutoff was 10 micrograms per deciliter. We're looking at 5 micrograms per deciliter, and even that is too high according to some studies. So there just is not enough data, not just here, but nationally as well. So of course, for possible research comparing compliance rates across the Utah counties, what's happening in Bountiful? What was that one aberration all about? Is there a difference across physicians and clinics? If so, those who are screening more, what's their secret sauce? How are they doing it? Of course, we're a mining area. There's mining areas historically around here. Do we see higher lead levels there because of the slag from previous mining endeavors? And then, of course, using the benevolent computer overlords we now have called EMRs, can we somehow automate that system to help us screen, right? Of course, I want to thank Dr. Madsen for all that he's done for all of us. Miriam Gorder's our data mining expert at McKay-Dee, who has helped all of us, including the third years with their posters, kind of mine data. A lot went into this, and so we appreciate everyone's help. We'll take questions at the end.
Hello, my name is Derrick, Wille. It's good to be with you this morning. Today, the focus of my topic will be on the utilization of medical scribes in family medicine. I have no disclosures. I am returning to my hometown of Cody, Wyoming, where I'll be practicing as a family physician. I'll be doing outpatient medicine as well as some inpatient pediatrics. I'll have the opportunity to go to the hospital where I was born, so I'm pretty excited about that. In Cody, business is good. In a town of 8,000 or 9,000 people, I think we have 5 orthopedic surgeons. So if you've never been to Cody or Yellowstone, I highly encourage you to come visit. I prefer you to visit, don't stay. We pride ourselves in not having very many traffic lights. So, but moving forward, one thing throughout my medical training during medical school, as well as throughout residency, is this topic of physician burnout, which I think all of us have heard of and may have experienced at some point. So I went to Medscape, and they put out their annual survey, and they listed which physicians are most burnt out. As you can see here, family medicine actually ranks number 6, internal medicine, emergency medicine. Some of the primary care specialties are higher up on the list. And they asked, what contributes most to your burnout? Interestingly, number 1, not shocking to any of us, would be too many bureaucratic tasks, charting, paperwork, right? I think we can all relate to that. When we elected to proceed a career in medicine, we didn't realize how much paperwork we'd be doing, I think. Also, increasing computerization of practice, which I think between the first and then the third often leads to too much time spent at work, okay? So then came this idea of medical scribes. So research in other medical specialties has shown that the addition of medical scribes to the clinical team enhances physician satisfaction, experience, and productivity. My first exposure with a medical scribe occurred when I was a 4th-year medical school at University of Washington. I was at the Billings Clinic, and I was working with a dermatologist. And it was quite fascinating. He could go through 40 patients in a day, and he had 2 MAs that acted as scribes as well. So he would have a patient roomed. They would start taking some of the information. He'd walk in. He'd do his physical exam, explain what he was seeing with the lesions of the skin. They would document it. He would tell them what he wanted them to prescribe. He would look over it, sign it, walk out the room, note done. He'd go on to the next one. And I thought, wow, this is pretty awesome. He's just doing medicine right now. But then I started thinking, well, I have an interest in family medicine. Is this really practical for a family physician? I'm sure many of you hear the stories of the person that's walking out, as you're walking out the door, they say, oh, by the way, doc, I have some chest pain I want to talk to you about. And you go, oh, geez, here we go, you know? So, you know, is family medicine too broad? How do you create enough templates to actually have a medical scribe? Is it financially feasible? And the big question I had as well is, I'm too type A personality. Am I just going to go and correct everything that my medical scribe does anyways, and is it really going to save me any time? But if it did work, I thought, wow, this would be something of interest. So I looked at some research, and there's been some studies. In 2017, the Journal of Family Medicine came out with a study where they took 6 out of 7 providers in an academic facility who had 4 part-time scribes. They contracted with an outside vendor for scribe services, and the study actually showed that they had 5.1 fewer hours per week on documentation. Interestingly as well, their productivity increased from 9.2% to 28.8%, generating over $168,000 per year. So the cost of one of these full-time employed medical scribes was $39,000. So they had a return on investment of 112%. They also commented that patients had a high level of comfort with having a medical scribe in the room. In the Annals of Family Medicine, they also did a randomized controlled study which demonstrated that physicians had an overall improved satisfaction with the clinic while utilizing a scribe. They reported having enough face time with patients, and they stated that they had decreased time spent charting. And interestingly, the chart quality and accuracy was improved when a medical scribe did the duties as compared to a physician. So my hypothesis was that the proper utilization of scribes in family medicine decreases physician burnout, improves overall physician satisfaction, and aids in productivity. So using the help of several individuals in Intermountain, Tanner Clinic, as well as Ogden Clinic, I reached out and asked who is using a scribe that is currently a family physician. So I got 14 individuals that I was able to find. I got 11 of the 14 to respond to this survey that I created using SurveyMonkey, and asked them 17 questions, which I'll go through with you. Interestingly, individuals of these 11 that responded, some of them have had a medical scribe since 2015, whereas some of them just started in March of 2019, okay? But I wanted to present this data with the hope that it would, answer some questions that you may have been asking yourself. Do I want to get a scribe? Is this something that would be useful for me? Although this is geared towards family medicine, I think it's also could be applicable to providers in pediatrics, internal medicine, emergency medicine, etc. So on the left, I asked, prior to utilizing a scribe, how satisfied were you with your current career? And on the right, you'll see after using a scribe, how satisfied are you with your current career? So interestingly, prior to utilizing a scribe, physicians were neither satisfied nor dissatisfied on average, whereas following having a scribe, they were more satisfied. With regards to their career, prior to utilizing a scribe, how often did you contemplate leaving your current job? And after, how often did you think about leaving while utilizing a scribe? Interestingly, previously it was monthly. Now it's yearly or less. With regards to productivity, how many patients did you see prior to utilizing a scribe before? And how many do you see now that you have a scribe? Now again, this is self-reported. But interestingly, they went from 19.4 patients per day to 24 patients a day. Charting hours prior to utilizing a scribe, how many hours a week would you spend charting? And then after, decreased from 24.5 hours per week to 11.8 hours per week. I asked, what about personal life satisfaction? Prior to utilizing a scribe, most physicians were satisfied. After utilizing a scribe or while using a scribe, most were very satisfied. I also asked, how satisfied are you with your medical scribe? And the majority were satisfied to very satisfied. How many months did it take you to feel that a scribe was an asset to your practice? Most said within 2 to 4 months. Of course, we have some outliers at 10 to 12 months, but in general, it's quicker than I anticipated. And I asked, what is your current outlook regarding continuous use of a scribe? And most were very positive. I asked, if you had to do it all over again, would you utilize a scribe? All but one said yes. And then I asked the difficult question, though, would you be willing to utilize a scribe even if you had to pay for a scribe out of your own salary? And that was more kind of split down the middle. Now, I wanted to talk, though, this wasn't all blue skies. I asked them, what challenges do you have with a scribe, right? So a lot of them, the number one issue was upfront training for adequate documentation. So these are direct quotes from the survey that I took. Some said, getting her to understand how to organize the patient's story, listening for and documenting my bullet points. Another said, I still have to read every note. This can be time consuming. My scribe does not think like a doctor, so I end up having to edit. I still have to take time to review their charts. One mentioned that scribe was inadequately trained, had limited medical terminology. They recommended need for a formal standardized training for scribes. And again, of interest, in my previous study that I read and I talked to you about was that they had gone to an outside source to obtain scribes who had been trained, whereas most of the scribes or providers that I spoke with, they were just, they had to do the training themselves. They hadn't had any previous Icentra or whatever EHR system they were using. They hadn't had any previous training. Other issues were administration buy-in, getting my employer to agree to support my desire for a scribe. And then, of course, the other issue is the turnover of scribes. A lot of individuals that are wanting to be medical scribes sometimes see it as a stepping point. If you get a young guy or gal, they might be trying to get into medical school. So they do a medical scribe gig for a year, and then you spend 2 or 3 months training them, and then all of a sudden they leave, and then you're back at square one. So these were all things to consider before obtaining a scribe. But in conclusion, my study demonstrated that of these providers, they had improved career and personal life satisfaction, increased self-reported productivity, decreased time spent charting, and they all had an overall positive outlook of utilizing a medical scribe. Some of the limitations of this study, however, was selection bias. I was reaching out to individuals who clearly wanted to have a medical scribe, and I was asking them how their experience was, which ideally they were hoping that it would work out, and that may have shown through my study. Also, this was a self-reported survey. They mentioned how many they felt hours they were charting, how productive they were, and of course, in this area, I was only able to find 14 family physicians that utilized the scribe, though 11 of them responded, which was great. Moving forward, just some next steps to consider would be to consider doing more objective data collection, actually going to the numbers and seeing, has productivity truly increased from a financial standpoint? We could also ask, are wait times improved? And the big question that I also wanted to find out was, does physician satisfaction reduce job turnover rate? I think it would. And so the question is, if I'm more satisfied, even if I don't necessarily see more patients, does that mean I'm more likely to stay, and then, whatever company I'm working for doesn't have to have more recruitment costs, et cetera, to, fill in when I decide to leave? Also, we could find out, survey physicians who aren't currently using a scribe and see why they're not using one. Be interesting to know what truly is the turnover rate of medical scribes. Is it financially beneficial or more productive to have in-house versus outsourcing of medical scribes? And then lastly would be to go to the patients and actually find out, how do they feel? Do they feel comfortable having a medical scribe in the room with them? So I think that these are awesome, things to consider if looking at utilizing a medical scribe, and that's what I have for you today.
My name is Jonas Peterson, and when I graduate in July, I'll be joining Jeff David out at Weber Human Services in downtown Ogden on 26th Street. Our focus of care will be on patients with mental health problems and substance abuse, and we'll be providing preventive care and primary care for them. So today I'm talking about environmental radon levels and lung cancer risk. I have no disclosures. And my question really is, can a patient's risk of lung cancer be stratified based on their zip code? And previous residents have looked at zip code in relation to their likelihood of dying and things like that. And I think a lot of that gets back to their socioeconomic status. But really my question is, does their actual geography, their location, does that increase the risk of lung cancer? And so looking at the epidemiology of lung cancer, it's a major cause of cancer death. In 2012 alone, worldwide, there were an estimated 1.6 million deaths from lung cancer. And in the United States annually, there are about 150,000 deaths from lung cancer each year. 90% of those are attributable to tobacco exposure. When I was going through and collecting my information for this presentation, I found some interesting statistics from the NIH and the National Cancer Institute. According to them, from 2009 to 2013, there were more deaths from lung cancer than breast, prostate, colorectal, and liver cancer combined. And so, and comprises an estimated 13% of new cancer diagnoses. And if you look up at the top of the graphic from their website, in 2018 there were about 266,000 diagnoses of lung cancer or breast cancer, and with about 40,000 deaths from that. Whereas with lung cancer, there's a similar number of diagnoses or cases of lung cancer, but a much higher rate of death. And so this is why lung cancer causes so many deaths relative to all the other cancers. It's very hard to treat, very deadly cancer. There are a number of risk factors for lung cancer, and so obviously tobacco exposure being number one, right? We all know that. You smoked or you lived in a house where somebody smoked for years, you're at higher risk for lung cancer. And that by far is the number one risk factor. But according to numerous sources, as I was reading up on this, radon is actually the second leading cause of lung cancer after tobacco exposure. And so I remembered this like vaguely from med school, but it really was not something that stood out to me and I think is an underappreciated cause of lung cancer. There are other risk factors, other environmental toxins that can lead to lung cancer as well, arsenic, chromium, nickel, for example, and then there are some conditions like pulmonary fibrosis or HIV, which are felt to be independent risk factors for lung cancer. And then radiation therapy. So a woman had breast cancer, got radiation therapy. She's now at higher risk for developing lung cancer, secondary to that radiation exposure. And so what is radon? Well, radon is a colorless and odorless gas. It's the last of the noble gases, and so it's relatively inert. It doesn't like to participate in chemical reactions because it is satisfied with its electron valence, and so it's actually a product of the decay of uranium-238. And so uranium decays to radium, which subsequently decays to radon. And I actually have a graphic here that shows the radioactive decay chain for uranium. And so let's see, I got up here at the top is uranium. And through a series of both alpha and beta decay, it is trying to, a radioactive element has an unstable nucleus. It wants to decay to something that's more stable. And it actually ends up down here, which probably you can't see because of the tables, but it decays to lead, which is stable. And for Rusty's presentation here, shout out, lead, bad. So right here, you see radon. The most important isotope being radon-222. And so, and it's actually not radon itself, right? So radon is a gas, you can inhale it, but then radon decays into, it has two daughters, polonium-218 and 214, that are metals that are deposited into the bronchial epithelium, and as they decay, they emit alpha particles, which are thought to cause damage in the bronchial epithelium, leading to cancer. These radon emissions are felt to cause mutations in DNA repair genes or possibly alter the production of cytokines. Through studies, radon has actually been linked to all histologic types of lung cancer in never smokers. And so why do we care about radon? Well, uranium, it's in the Earth's crust. Back on that graph, it showed that uranium has a half-life of like 2 or 4 billion years, and there's a lot of it, and it's continually decaying and producing radon. And radon has a half-life of about 3.8 days. And so we build our homes into the earth. There are cracks in the foundations or joints in the structure, or the pipes are entering the foundation. And in those locations, radon can seep into your basement. It's about 8 times heavier than the atmosphere. And so it settles in the lower parts of your home and can get to dangerously high levels. The first association of radon and lung cancer was actually with uranium miners. As they're mining uranium, there's high levels of radon, and they had, independent of any tobacco exposure, a much higher risk of developing lung cancer. And so at higher concentrations, you're more likely to develop lung cancer. So that's why we care, and we already learned that it causes lots of deaths. It's difficult to treat. So in my study, my hypothesis was that high radon levels in a given zip code will increase your risk of developing lung cancer. And I collected my data from a single healthcare system's EMR. And for any patient with a diagnosis of lung cancer, any of the ICD-10 codes of lung cancer, I asked for their zip code, their gender, and their history of tobacco use. And there were about 1,400 patients, half and half male, female. 32% were smokers, 66% non-smokers, and 2% had an unknown smoking status. There were 133 unique zip codes that were evaluated. And if the population had less than 1,000 people, we excluded it because of low numbers. We didn't want to skew the data. And then I calculated the rate of cancer, the number of individuals with cancer per population for everybody combined, and then smokers and non-smokers individually. And I collected the radon data from the Utah Department of Environmental Quality, who publishes information regarding radon levels based on zip code. And specifically, I was looking at, so it gave me the zip code, and then for the percentage of tests that came back with less than 4 picocuries per liter, which is the way that they measure concentration of radon, or greater than 4 picocuries per liter. And so you can see those there. And the Environmental Protection Agency actually, so average across the United States indoor radon level is 1.3 picocuries per liter. average outdoor is 0.4, and then the EPA has defined 4 as the risk level. Above 4, you should undergo some type of radon mitigation in your home. And so I graphed this data onto the zip codes of Utah. And so a darker shade of purple means a higher percentage of tests that were greater than 4 picocuries, or in other words, the darker the color, the more radon. At least that's what we're assuming. And so, just to kind of graphically see what it looks like, and this is our area a little more closely. I graphed the rate of cancer onto each of those zip codes and just kind of looked at it visually to see if there appeared to be any type of trend. As I was looking, and this is for both smokers and non-smokers combined. As I was looking at this, I kind of imagined to myself that some of these areas where it's more lightly shaded, the rate of cancer was lower, and then I'm looking over here where it's darker and they're higher, like maybe there'll be some type of association. I did this for them combined as well as for non-smokers. And again, this is more closely zoomed in on our area. Kind of looks very similar to the combined as well. And then I did the same thing for smokers. And so kind of the whole state and then our area zoomed in more closely. And so really, looking at it, it was hard to really see a clear association, although I was kind of imagining it to myself at least. When I plotted this data out, I have on the x-axis is the percentage of radon tests greater than 4 picocuries per liter. Again, that being that cutoff of safe or dangerous, anything higher is dangerous. And my y-axis is essentially the rate of cancer, and each dot represents an individual zip code. And this particular graph is for non-smokers, and we really didn't see a trend. Trying to analyze this, I added in a trend line for it. There's really no significant slope to indicate a correlation. And similarly for smokers, the data looks very similar, and my trend line actually has a negative slope, which would suggest that higher radon concentrations is a good thing. But we know it's not true from more rigorous studies. And so, but there are a number of limitations to my study. Number one, the zip code was just what was listed in the EMR. There was no indication as to whether or not that was the zip code when they were diagnosed, nor how long they lived at that zip code. And the data was from a single EMR, so we didn't capture a lot of people because of that. And some studies, probably most interestingly, it was like 3 months ago, there was a study published that actually suggested that in this low range, the 4 to 8 picocuries per liter actually is not dangerous, and that it can be protective against lung cancer. And they hypothesized that was because the radon stimulates the immune system in your lungs and prevents the development of cancer. Although there were a couple of other studies, one of which was rather large that is cited frequently in radon literature, that did find a risk of lung cancer even at low levels, even at 4 picocuries per liter of developing lung cancer. So there's some debate as to what's the actual level of radon that becomes dangerous. And so my conclusion is that radon is the second leading cause of lung cancer, something to think about. But using a single healthcare system's EMR and publicly available radon data, at least, I could not draw a conclusion between risk of lung cancer and zip codes. It would be interesting to look at, what does their construction type, above ground versus below ground dwellings, or maybe more generalized data, building a house now, and our contractor, when I asked him about radon mitigation, he's like, oh, you're building too far from the mountains. It doesn't matter out here. Radon levels are too low to worry about. And so that was I didn't find anything that really suggested that was the case in my searching. And so that would be an interesting question. Does being close to the mountains versus farther away have any association with radon levels or risk of lung cancer? And then just for your information too, radon, there are commercially available radon kits. You can buy them online and test your home for radon levels. And then your levels are high, there are several companies in Utah that offer services. Their websites don't list prices. They say they'll come out and give you a bid, but when I tried to find out how much does it really cost to have your house protected against radon, online it said it ranges anywhere from $800 to $1,500 to have that installed. And so basically they go to the lowest part of your home and put in a little ventilation system, and it kind of pipes out of your house. And so that is my study.
I'm too short. Last one, guys. If I can ask you to just stand up and stretch a little bit. Or just stretch, and yeah, that's good enough, I guess. I'm really short here. I'm Val Diaz. I'm one of the residents. Thank you. When I'm done with residency, I will continue to be a nomad, which I've done my whole life, working as a locum tenens provider for the next 5 years or so. My first assignment will likely be at Midtown Community Health Clinics, where I've done my continuity work and have developed incredible relationships with my patients. I have nothing to disclose. I will be presenting on restrictive environmental stimulation therapy for the treatment of concussion, acute concussion symptoms. Our overall question was, can inducing a deep state of relaxation in patients with concussion, can that actually improve their concussion symptoms? We had a wonderful lecture yesterday on traumatic brain injury. So hopefully most of you guys were here. But overall, concussions are traumatically induced transient disturbances in the brain that involves a very complex and poorly understood pathophysiology process that we believe leads to a mismatch in energy utilization in the brain. It does affect, in 2013, affected 3 million people. The most common cause of it is falls, and that's followed by being struck by an object. And within that, 25% of those are sports-related. And within sports-related injuries leading to concussion, females are actually more affected than males. The symptomatology of concussion is complex, but patients can be a lot of times debilitated by some of these symptoms. They are physical symptoms such as headache, which is the most common symptom, nausea, vomiting, poor balance, cognitive symptoms such as poor concentration and poor memory, and psychological symptoms such as anxiety, depression, and irritability. During my residency, I had a chance to take care of multiple patients with concussion. And most of them wanted to get better faster, to get back to work, to school, and to their sports activities. And I felt oftentimes powerless in that all I could tell them was, well, keep your activity levels to a level below the threshold at which their symptoms were exacerbated. We then learned that multiple Weber State athletes with concussions were actually reporting faster rate of recovery of their symptoms when they took part in a therapy called restricted environmental stimulation therapy, or REST. Oh, there's no sound.
Get away from
there you
all
go.
the stimulus that's constantly bombarding us.
And this is what REST is.
How sensory deprivation therapy works is we have a large flotation tub or tank, if you will. The pods are filled with over 900 pounds of Epsom salts, and it's heated to skin temperature. It's only 10 inches deep, but when you get into it and you start to float very high on the surface, you lose the sensation that you're touching anything, that you're even in the water. So you get the sensation that you're actually floating in space. Most people come out and talk about the immense calm and peace and serenity that they feel. And a lot of times the float sensation, that calm and peace that you get, lasts for several days afterwards. We get a lot of athletes that come in and like the benefits that the Epsom salts gives them. Epsom salts is magnesium sulfate, and because of the high concentration in the float pods, the magnesium goes into the body and it starts to get rid of lactic acid, which releases muscles and gets rid of tight, cramped, sore muscles, as well as it's great for reducing bruising and reducing swelling. People that come in for more creative reasons and take more advantage of the sensory deprivation aspect, it frees the mind up to kind of travel and be extremely creative. Also meditators, a number of
So we know, and that it is when you are in one of those pods devoid of sound and noise, the temperature of the water it's heated to skin temperature, and you do feel that you are comfortably suspended in space. And that induces a deep state of relaxation similar to that that you feel when you're about to fall asleep. I actually fell asleep in one of these pods. So we do know that rest, there is good data suggesting that rest is beneficial for people with anxiety, depression, stress, chronic pain from whiplash injuries, and muscle aches after intense exercise. So with the anecdotal information from the Weber athlete students with concussion, we wanted to find out more and see whether rest therapy could actually have a good impact in patients with concussion. With the support of Intermountain, financial support from Intermountain, we were able to do a pilot study, and it's an ongoing study, a small prospective cohort study to look at that, with the hypothesis that rest for an hour improves symptoms of acute concussion. So our design of this study, the population we wanted to focus on was the Weber State athletes, and patients that were referred to our McKay-Dee Hospital Sports Medicine Clinic at Porter Clinic. To be included in our study, the patients needed to be over the age of 18 and have a concussion that was less than 6 weeks old. They could not be in the study if they had any open sores, current menstrual flow, any sort of mental disability that would preclude them from safely entering and exiting the pod, epilepsy, renal clearance issues, and a severe traumatic brain injury. They were asked to continue to log their daily symptoms, which providers who take care of these patients are familiar with that form, but also complete 3 of those rest sessions within 7 to 10 days upon entering the study. They were also asked to complete a survey, a pre- and post-flotation survey, to look at all of the symptoms that were affecting them. The physical symptoms, headache, nausea, neck pain, the psychological symptoms, and the cognitive symptoms. And overall, how they, if they had any issues with the flotation session, or and how they felt overall after the session. So again, it's an ongoing study. We have been able to enroll 4 patients so far. All of them were women between the ages of 18 and 45, with an average of 1 previous concussion. None of them had serious brain injuries. And overall, the median of 2 days from the day of the accident to the diagnosis. 2 of them had concussion related to sports, a ski injury and a soccer injury. 2 of them from a motor vehicle accident. 2 of those patients did have a previous history of migraines, and 2 of them were already taken an SSRI. This is our raw data showing that there was a overall decrease in symptoms, all of those symptoms except for nausea. There was more reports of nausea after the sessions. And overall, the average symptoms that they came in with compared to after they were done with the study was significantly lower. Delving a little deeper into the data, we're able to show that this is the symptom, overall the symptom score and the days since the injury. So we're able to get the 4 of them really early in the process. And overall, as we learned yesterday, people with mild concussions, they are supposed to improve, and they're supposed to be better by 1 to 3 months. So we do see that decrease in symptoms overall pre-flotation, but there was a significant decrease in symptoms after their flotation sessions. Furthermore, in this graph, we're able to see that, so this is again the average symptom score, but this is the flotation sessions, first flotation, second flotation, and third. And again, that average decrease overall in symptoms as time goes by, but a significant decrease after each of the flotation sessions. We see here that the symptoms did come back a little bit after their first flotation session, but decreased significantly upon their second and third flotation sessions. So in summary, this is again still ongoing pilot study, but we did see that rest did decrease symptoms and led to an improvement in concussion symptoms reported by the patients. Overall, 100% of those patients have gone back to school, have fully recovered, reported that they have fully recovered from their concussion. They denied any negative side effects from these sessions, and they would recommend that therapy for other patients suffering from concussion symptoms. And this is especially significant in the setting of the population that we had, women with a previous history of migraine, previous history of anxiety and depression. And it was nice to see that they have all recovered. Next year, Haley Emerson, one of our second-year residents, will be presenting on the final data from this study. We are hoping to enroll 20 patients total. Once we have that study done, the next step is to proceed with an actual randomized controlled trial, and hopefully we'll be able to answer questions such as, is there an actual difference in rate of recovery when we use float versus just sitting in a quiet room? Can we actually help people with those chronic concussion symptoms? And is it actually helpful for young athletes? And is there a difference in concussion symptom resolution in patients that suffered from a sports event versus an accident? These are my references. And I wanted to take some time to thank this is our team right here, and I had to include Haley right there. She wasn't there that day. But Dr. Clark Madsen, he is right here. He was a stellar resident and now has become one of the, let's see how I say this. Well, he's an excellent faculty member, and he's an incredible addition to our program. I know that we're very grateful to have him. I know that he's going to be very successful in his career. He's incredibly intelligent and humble about it. Wanted to thank Keith for letting us use his business to have our patients come in and get their flotation sessions done. But mostly, really, my co-residents, we have gone through a lot together. We have burned out together and recovered together. And I love them, and I'm going to miss them on 10. Thank you.
Come take a seat. So as they take their seats, we'd like you to be thinking of your difficult questions. The more difficult, the better.
Aren't you supposed to be on our side?
I am on your side. So I have a question first. Dr. Wille, you're going to Cody, Wyoming. Do you have a scribe already or not?
No, but I want one.
Okay, please go to the microphones. We'll start with you, sir.
These were really excellent presentations. I want to congratulate the residents on their work. I had two questions. First is regarding the ski. Have you been able to correlate any of the lighting, whether it's an overcast day versus a bright day? So that certainly affects how people ski. I wonder if you're able to document that.
That's certainly one thing that we did consider, that I ended up, when I was gathering the weather data, I came up with 125,000 lines of data. So it took a lot of analyzing just to get the information we had. So we weren't able to look at that. I think that's definitely a next step that we would look at, because that, in addition to snow surface conditions, I do think play a significant role.
Excellent. I just had one more question for Dr. Vargas. In the little video, it implied that the magnesium is taken in by the body to have certain pharmacologic effects. Have you been able to test the serum levels of magnesium before and after exposure to this flotation device?
Not us personally, but we have been able to, when he mentioned magnesium in the setting of muscle aches, we have been able to measure lactate levels, which were significantly decreased in people who had just undergone like intense exercise.
But no
So that's-
correlation with serum magnesium.
Correct.
Can I just add to that really quick? Sorry. So, interesting, one of our exclusion criteria for the study is renal failure, because there have been some studies that show you can absorb it through the skin, and people will urinate higher levels of magnesium afterwards. So we take that into consideration as well, but whether that plays a role, we don't know yet.
Dr. Latica? It's shorted out because of cannabinol use. It just doesn't work anymore. Okay, we'll get to this one. Dr. Abdullah.
Yeah, I enjoyed those also. Derrick, you mentioned that most snowboarders on their first day get most of their injuries. Why is it that they always have to have their back foot not in the bindings? I've used clickers forever, and I'm always clicked in when I come off the lift, and most of the guys that are just learning, when they come off with one leg out, they're running into other people. It seems like it should be allowed for them to have their back foot in the binding.
I think the issue with that is loading up onto the lift. I think it's hard to load up onto the lift if you can't have one foot out to scoot forward. So,
But I click
Yeah.
in as soon as I get on the lift.
but you're right. There's all sorts of things that we might be able to look at in the future based on the information that we see. So that's certainly something we could look at is, are there more injuries as people are getting off the lift for the first time? Where do those injuries occur at the resort? And so we might be able to look at that and say, hey, maybe we can make suggestions that they do stay strapped into their bindings, or that they do have additional safety measures in place. So I think that's something that we could definitely look at. Thank you.
Courtney?
All right. I thought some of these presentations were some of the best among all of the presenters, so congratulations. This question is for Dr. David. I'm hoping you can help distinguish between chronic pain and opioid abuse, because sometimes the only difference is the physician that's willing to prescribe high doses of opioids.
That's kind of the conclusion that we came to, is oftentimes there's a lot of overlap. And if we really looked at most of our patients that are on full agonist opioids for chronic pain, many of them will have multiple criteria of opioid use disorder. And opioid use disorder is stratified as mild, moderate, or severe, depending on the number of those 11 diagnostic criteria that you meet. And the higher that number, the more they progress from that mild to moderate to severe, the more likely they are to benefit from buprenorphine. I can't give you, what delineates one for another. That's kind of the conclusion I came to at the end of the study is, hey, everybody kind of falls into this to some degree if we've got them on, or at least many people that we've got on chronic opioids do fall into that category. So.
So interestingly enough, I was attending on the day that Jeff David saw his very first patient as an intern, who turned out to be an incredibly complex narcotic drug-seeking patient. And I thought we were going to have to either restrain or sedate Dr. David, and here he comes full circle and is going to be taking care of those exact patients, and I suspect doing fabulously.
It left a deep mental scar, as you can tell.
Grace.
I have a question regarding the scribes. Now, the scribes that you utilize, do they have to go through special training, or is it on-the-job training? Are they just MAs that are trained? That is question number one. And question number two, did you calculate how many more patients per month you need to see in order to make this a break-even proposition? Because I would love a scribe. I just thought I couldn't afford one. But can I get that information?
Okay. So with regards to your first question, so here with the scribes that I spoke with, the majority of them had, they did on-site training. So that was one of the challenges, whereas, some of the studies that I read, they had outsourced. So they had these companies that would spend, 4 weeks training individuals on certain EHRs, what to do, et cetera. And then I think that went more smoothly, whereas the providers that I spoke with and surveyed, most of them had to do the on-the-site training, and that was one of the frustrating parts. With regards to your second question, I had done some digging around. Patrick Hall, our clinic manager, he looked into it for me to hire a medical scribe. On average, starting out, they would be about $30,000 salary, but total cost would probably be around $40,000 if you gave them benefits and such for the company. But I didn't do any calculations of, exactly how many more patients do you need to see to break even. I've heard anywhere from like 2 to 3 extra patients a day. But again, I'm not entirely sure, depending on, the specialty or if it is with family medicine.
Okay, thank you.
So before we get to the next question, by show of hands, how many of you are using Scribes? Some. Put your hands back up if you use them. Are you happy that you have Scribes? Keep your hands up if you are. That was pretty good. Small sample.
Hi, is it Dr. Peterson who talked about the radon? Okay. I just was wondering how radon was tested, whether that's something that's like tested in the dirt in the different zip codes, or like from people's in-home testing. And then I was wondering if there's an effect on socioeconomic status, because there could be higher radon potentially in a neighborhood, but obviously it's a luxury and a privilege for a lot of people to be able to test or even set up like a device to get rid of the radon in their home. To me, that's something that socioeconomic status could affect.
Yeah, thank you. Good question. So the radon kits, you can buy them online. They're only like $20. Actually, I bought one years ago when me and my wife were in our first apartment. That was a little bit of a questionable apartment. And it was like on a deal for only like $5. They were running some kind of promotion. So it's actually not very expensive to test. And you're supposed to set it a certain number of inches above the ground in the lowest room in your home. And then you send it in to a company, and they will give you the results on the level. And so some of the studies, though, that were really actually very extensive studies, published in these like journals of epidemiology regarding like environmental things, and they actually had continuous radon monitoring in homes that would give them updates every few minutes, like every 10 minutes or something like that. So they had pretty sophisticated equipment. And so the tests that were done here in Utah are just like a slice in time, what was the radon level. And there were a certain number that they did in each zip code. We tried to, like I say, cut out the zip codes where when they had low populations, they didn't do a lot of tests. And so that's part of the reason why we got rid of those populations less than 1,000, because they only had like 2 or 3 tests in a zip code. And so we used the ones that had higher numbers. And then in regards to socioeconomic status, I think that is a good question. I didn't do anything to address that, but I do think it's a good question, because it seems like there could be a correlation. Like in Europe, in some of the older structures, they have some of the highest radon levels in the world. And across the United States, I saw that it was like the Appalachian region and Ohio, or Iowa. It was Iowa that have like the highest levels of radon. And so I think it would be interesting to look at socioeconomic status as well, but I don't have anything about that.
So how many of you have tested for radon? Quite a few. So put your hand back up if you had to do something about it. Some. Okay. Dr. Allen.
I'd also like to congratulate the residents on the presentations. I thought they were all great. I have a question for Dr. David. What is the abuse potential or the dependency potential of buprenorphine?
So I don't have a way to quantify that, but it's a Schedule III medication in comparison to the Schedule II opioids that we more frequently see with hydrocodone, oxycodone, et cetera. So it's less. It is still an opioid. There absolutely is still a potential for abuse and a street value for it specifically. Oftentimes and that's where I see more, it's hard to abuse buprenorphine in the sense of getting euphoria from it, but more frequently what you'll see with patients is the potential for diversion because of its value on the street in protecting people from withdrawals until they can afford heroin or something more intense later on. So it isn't completely benign, but it is much safer in comparison to the other full agonist opioids. Again, when you look at its potential for respiratory depression, CNS suppression and sedation, and that motor vehicle accidents and things that are associated with that. So I'm not sure if that answers your question.
Yeah, that's great. Thank you. Question for Dr. Wille. My experience has been that it works well if the scribe is also an MA. The person can actually perform 2 functions and be very helpful in both those, and also easier to train somebody who comes out of an MA experience into doing the scribe work. I don't know if you looked at that or would consider that.
Yeah, so again, in this particular study, I didn't ask specifically if it was medical scribe versus MA/medical scribe. I do know that there is a little bit of a cost difference. Patrick Hall have looked at that as well, if you have them doing both aspects, but it's not much. But yeah, I've heard the same.
Yeah. Just one other comment. The experience with skiing, I have a dear friend who fairly recently was killed skiing because of visibility. Not just overcast, but visibility. That might be something worth looking at too.
Yeah, I agree. In fact, kind of when I was telling the story about my trip to Japan, I think that was more the thing that made me get injured. So I broke a rib because it was low visibility skiing through trees. So.
Chelsea?
I have a couple questions. My first question's for Dr. Diaz. I was wondering if when you were doing the surveys and talking to the patients in your study, if you have any sense for how long the effects can last, because we saw that the symptoms did return before their next session, but how long was the improvement? Was it, hours, days? Did you get any sense for that in your questions?
They kept a daily symptoms form, and it was days.
About how many days? Do you know?
A few days.
Okay, that's very helpful. Okay. My second question is for Dr. Stodmeister. And my question for you is if you were able to identify what factors are preventing us from screening?
That is the question, right? And looking at it, especially primary care, pediatrics, we're required to do so much. There's so many other recommendations. While I haven't seen any studies other than a couple of quotes here and there in other writings, it's essentially just physician-based. Either the physician not being aware of lead level screenings in that area, or just being inundated with so many other things that, that's the least of their worries. Talking with some of the local pediatricians about it, some of them just say, that's a good thing. I've never really thought about lead level screening before. So it's just one of those things that has just kind of gone under the radar, right? And so because of that, we just don't know if there is or is not a problem. But it'd be interesting to see, or to ask around, a survey to see, A, if they know the recommendations, or B, do you care? So.
Right. And my last question is for Dr. Hall. I was wondering if you were able to see in the data whether they were using their safety equipment at the time of injury, or if there was any correlation with that.
Based on the charts that I reviewed, I could not. They had no indication of whether they were using safety equipment. Some notes did, but the vast majority did not. So that would be a little bit more difficult information to obtain. One thing that I did see in the research and the data is that over the past decade or so, there's been a substantial increase in the use of helmets. It's become more the common thing and not the exception. It used to be in the 1990s that nobody wore a helmet, and now almost everybody does. About 80 to 90% of participants use helmets. So there's that data, but I wasn't able to find any data in the charts that I reviewed.
Okay, so mine is partly a question and partly a comment regarding the scribes. So I had reached kind of a little bit of a burnout, and so the administration wanted to keep me on, and so they said, hey, we're going to have your nurse be your scribe. And so she went in with every patient. She had the medical knowledge. She could do it. I could just look over and say, hey, that looks great, or no, change this or that. It was very simple. It definitely increased my productivity, and it helped me a lot in my attitude. But I'm just wondering now, has anybody looked into hiring? There's nurses out there that are maybe done with wanting to be, bedside nurses that could do this kind of work. And I think that ought to be something that, have you looked into that? Has anybody, wondered about that? Not just an MA, because the MA sometimes doesn't have, like you said, the medical knowledge. They may have the terminology, but not the medical knowledge to put it into a good flow.
Yeah, I didn't look into that specifically. One other thing, though, that I wanted to mention with regards to kind of the productivity and such, though, is it's going to be interesting as well as with like healthcare changes, going from a fee for service to like a capitation model. I don't know how medical scribes is also going to play a role with regards to that as well. So, but I didn't look at specifically nurses versus MAs versus just medical scribes.
Dr. Johnson?
Sorry, another scribe question for Willie. So did anyone say anything about how it works when you have a student with you, someone shadowing, or if you're training medical students or residents or nurse practitioners who are with you? Now you've got two people in the room. How does that work, and has anyone had that experience, or do they just have to sort of not do that anymore because it would be awkward to have two people in addition to you in the room?
Yeah, that's a good question. I didn't ask specifically about that. I think most of the providers that I contacted were, family physicians, especially kind of in the latent group that don't really have residents following them much. I know from my own experience with, dermatology, and then also I worked with Dr. Anderson with ENT. He had his MA scribe there, and sometimes it would feel a little intense when there's 3 people walking in the room to say hi to this one patient. But I don't, again, I think that would be one of the next steps would be looking at patient satisfaction experience. Do they feel comfortable and to what level, But
I want to make a comment on that.
Go
if I
ahead.
can.
Yep.
So, kind of just more, not specific to a scribe, I guess, but it seems to be more related to the physician than anything else, because, for example, everyone knows Dr. Mosinger, general surgeon at McKay, who has a train of students with him at all times, and seems very comfortable with it, and his patients understand it and are okay with it, and he doesn't let it faze him at all. Whereas others, I work with them one-on-one, and they're uncomfortable to just have me, a resident that's almost done with residency, going in there. And so it's very provider dependent. I think if people are interested in and excited about education and having students and residents in there with them learning, then they do a great job, and there's no awkwardness for essentially anything, whereas other providers sometimes make it a little awkward by asking the patient, oh, is it okay? They're just learning, and so it's somewhat provider dependent.
Thank you. So Dr. Arain donated her husband for part of Derrick's studies, so you have the microphone.
Thank you. Well, I just wanted to congratulate all of you on amazing presentations. I'm so proud of you all and wish you all the best in your future endeavors. So Dr. Hall, I had a question for you. And as Dr. Wille and Dr. Campbell know well, so my husband broke his leg skiing recently, and it was a beautiful day with great clearance, the most amazing powder day. And my question for you was, did you look into at all skill level of the skiers? Because for him, he was at a point, he had never skied as a child. So we moved here 3 years ago, so as an adult was his first time skiing. And he started out horribly, but was finally improving, and gaining some confidence and becoming a more skillful skier. And that is precisely the day that he fell and fractured both his tibia and fibula. So
I think there's definitely something to that. I think that could maybe be further investigated by conducting patient surveys, for example. We didn't specifically look at that in particular, but in the background research, what I did see, though, is that among snowboarders, like I said before, almost 50% of injuries occur on the first day of skiing. In addition, in the data that I did gather, we looked at in-state versus out-of-state, which could potentially be a surrogate marker, because most people that are skiing consistently in Utah probably have a little bit more experience than people that are coming in. And maybe it's just familiarity with the terrain. It's hard to make that specific tie. But that could be an indication that maybe there's some skill level that increases the risk of fracture if you have a lower skill level.
well, I think for him too, it was, or in this particular circumstance, it was right at that point where you're going from being a poor beginner to maybe like a, a little, not advanced, but moving your way up. And so, and there was actually that day in the clinic a young man from Arizona who also broke his leg, and they both got transferred to IMED to have their surgeries done. So,
and it is really interesting, having worked in a few ski clinics. On certain days, there are, like when I was reviewing the data, the patient encounters, there were some days where I would see 5 shoulder separations and no other injuries, and then there was some days that I would see 3 ACL injuries, but no other injuries. And so there's got to be something to that, in my opinion. And so it'd be interesting to look at. I think the information that you're talking about, I think the only really real way, I'm detailed in my notes that I do for the most part, but I don't get that detailed.
Sure.
And so I think you'd have to conduct some patient surveys, and that certainly is something we could look at in the future.
And then just a comment for Dr. Stodmeister. So I did my residency in California in a very, in the San Joaquin Valley, and so we served a very underserved population. And for those children, we actually did lead level testing at their 2-year visit across the board. We didn't even, it was just such a highly at-risk population that we just tested, and it was very routine. And we did catch a good number of kids that may have been lost if we were trying to narrow it down. I know the AAP has kind of changed those guidelines, and when I moved out east, it wasn't as predominantly tested, but for us, it helped us catch some of those kids we may have missed. But thank you.
Yeah, just a quick comment on that, and that's one thing that I think speaks to the future of how some of these preventative care things will go. Eventually, I think the electronic medical record system will catch up to us, and we can develop algorithms where that testing just becomes automatic. So yeah, we can start catching some of those. And I did read a couple of papers actually coming out of California about lead level testing and the importance of it because of high areas, in California and in Michigan. So, I think it's definitely worth looking at our screening recommendations, get some data on the book so that we can, make better further decisions.
So do you remember the old Rsks cameras that you had your high school graduation picture taken and somebody inevitably ran from this side over to that side and got there before the camera got there? So Dr. Abdullah started over at that microphone and now he's ending at this microphone. So what's your question, sir?
To Dr. Wille, you identified a problem. The problem is that there is a need for a scribe. And there definitely is. I have several family members in the medical field, and they hate medicine because of the electronic medical record. Many of the people here without hair and with gray hair don't know what that is, but it has ruined medicine as I have talked to people. Everybody is dissatisfied. You go to the doctor's lounge, everyone is talking about how bad the electronic medical record is. Instead of adding scribes, I think it would be more beneficial to find out a way to get around that, because it has ruined medicine. It has ruined eye-to-eye contact of doctor and physician. It has ruined how 2-3 hours a day that people spend doing the electronic medical record that was originally designed to help physicians treat patients, and it has hindered them. Many doctors don't get home till 10 o'clock at night because they're doing the electronic medical record. And I don't know if it's helped medicine. From me talking to patients and other people that I see, that you have identified a problem, a need for a scribe because of the electronic medical record. It really needs to be looked at. Where are we going? Because many people don't want anything to do with medicine because of the electronic medical record. Just an editorial.
Yeah, so solve that, Dr. Wille.
Well, yeah, and talking to some of the physicians, they mentioned it's kind of frustrating that you go into a medical career and then your productivity is based on your typing skills. And if you were a C student in typing, that means you're not a good doctor. So it is a frustrating thing right now.
So the lunch is getting cold. So it's time to break for lunch. Let's have a round of applause and thank you very much for your participation.